to join.
Good morning. Today we are having a case discussion on hyperthyroidism. Dr. Komal Sharma, who is a third year MS junior resident at IPGMS Hospital, will present, and Dr. Ujjal Bhatt is trying to join. I'll also be in the session. Dr. Komal, you can share your screen and present. Wait, at the end of history, we have some discussions and then pass on to the examination and then final discussion. Yes. Komal, you can share your screen. Yes, please. Yes.
Good morning to everyone present. I am Dr. Komal Sharma, JR3 from IPGMER, and I shall be presenting a case of thyrotoxicosis. My patient, aged 54 years, female, homemaker by profession, hailing from Diamond Harbour, presented to the surgery OPD with the chief complaints of firstly, a lump in the front of the neck for 5 months, loss of weight since 4 months, and trembling of hands since 1 month. The patient was apparently well 5 months ago when she noticed a lump in front of her neck on both sides of the midline, more on the right. It was smaller to begin with, initially on the right side only, but gradually increasing in size to its present dimensions of 4 by 5 centimeters on both sides. The swelling was not associated with any pain or any difficulty in swallowing or breathing or any changes in her voice. The patient gives a history of loss of weight in spite of increased appetite over the past 4 months. She was unable to mention exact weight but reported her clothes getting loose. Since the past 1 month, the patient has been complaining of trembling of her hands, heat intolerance with excessive sweating, palpitations, occasional loose stool with increased frequency, inability to sleep through the night with episodes of waking up feeling anxious, difficulty in getting up from bed, easy irritability, and some bulging of eyes noted by her relatives. She does not provide any history of chest pain, exertional breathlessness, or decrease in vision. She has a past history of 2 cesarean sections, one at 19 and one at 23 years of age. No history of any other surgery or major illness in the past. Patient was started on some medications by another doctor 1 week ago, after which there has been slight improvement of symptoms. The bowel habits are altered. She has episodes of diarrhea. Bladder habits are unchanged. Appetite has increased. Sleep has decreased. The patient does not have any known comorbidities like diabetes or hypertension. There are no known addictions, no known allergies. The patient consumes a mixed diet. She is para 2+0, no menstrual irregularities in the past, and she achieved menopause 12 years ago. She has no history of any such complaints in first or second degree relatives. Both parents are deceased, no significant medical or surgical history about the parents elicited. She is married with 2 children, 19 and 23 years of age. Summary, my patient, a 54-year-old female, presented with complaints of swelling in front of her neck for 5 months, gradually increasing in size, presently 5 into 4 centimeter on each side of the midline, painless, not associated with any respiratory difficulty in swallowing or voice changes. There is history of weight loss despite increased appetite, limb tremors, heat intolerance, insomnia, easy irritability, diarrhea, muscle weakness, and palpitations. The relatives have noticed bulging of the eyes for past 1 month. The above symptoms were relieved on starting some medications around 1 week ago. There is no significant past history or family history. She is married, has 2 children, and has achieved menopause 12 years ago.
Okay, Komal, going through the history,
Yes.
what do you think the patient is suffering from in view of the swelling in the front of the neck and the symptoms she has?
So the swelling in front of neck is likely to be a thyroid swelling with features of hyperthyroidism. And as patient also gives history of bulging of eyes, she probably has thyrotoxicosis, sir. So, sir, this could be a probable case of Graves' disease, sir.
Yes, you have used the term thyroid, and the term was there also thyrotoxicosis. What is the difference between these two terms, hyperthyroidism and thyrotoxicosis?
So hyperthyroidism refers to increased circulating quantity of the thyroid hormones, while thyrotoxicosis refers to the symptoms due to hyperthyroidism, sir.
So, can there be thyrotoxicosis without hyperthyroidism? Can there be in thyrotoxicosis in
So
spite of there is no hyperthyroidism?
sir, there might be exogenous intake of thyroid hormones, excessive intake of thyroid hormones.
So the basic difference is, if you say hyperthyroidism, that means in that case, thyroid gland is secreting excessive hormones.
Yes, sir.
That is hyperthyroidism, and the manifestation because of this increased hormone we call as thyrotoxicosis in view of the cardiac symptoms and other symptoms.
Yes.
And this thyrotoxicosis can happen in some other situations, like, as you said, exogenous increase of intake of L-thyroxine, which is known as factitious hyperthyroidism.
Yes, sir.
Or it can be a situation of thyroiditis. In thyroiditis, in the initial phase, patient may have features of thyrotoxicosis.
Yes.
That is not because why that happens in thyroiditis. Why there is features of
preformed thyroid hormones, sir.
These hormones are released.
Yes, sir.
There is excessive release of this thyroid hormone, but there is no increased synthesis.
Yes, sir.
In hyperthyroidism, there is increased synthesis of hormones. In thyroiditis, whatever hormone has formed in the thyroid gland is being released in circulation because of thyroiditis. So this is a basic difference. You may have thyrotoxicosis in absence of increased hormone being synthesized and secreted. Okay, this patient is having these symptoms. Why these symptoms occur in hyperthyroidism? What is the basic mechanism of these manifestations?
So the thyroid hormones, they increase the basal metabolic rate.
Yes.
And also they have a permissive effect on catecholamines, sir, because of which the symptoms occur. So
this basically leads to sympathetic stimulation.
Yes, sir.
So this causes these effects. Is a catabolic hormone. Is a catabolic hormone leading to increased breakdown of muscle mass. And these patients are having loss of weight in spite of increased appetite. Okay, so you think this patient might have a background of a thyroid swelling, and she has some symptoms suggestive of hyperfunction of thyroid gland. So that what we can gather from this history and examination. Okay, I think you can pass on to the examination.
The patient was examined after informed consent in a well-lit room with adequate exposure and in the presence of an attendant. First, the vitals were measured. The pulse was 102 per minute in right radial artery. Rhythm was regular. The pulse volume was normal, but it had a collapsing character suggestive of hyperdynamic circulation. Condition of the arterial wall was normal. All peripheral pulses were palpable and bilaterally symmetrical. The blood pressure was 108 by 70 millimeters of mercury in left midarm in supine position. The temperature was 98 degrees Fahrenheit in the right axilla. The respiratory rate was 16 per minute, regular, thoracoabdominal, and bilaterally symmetrical. The patient had an average built-in nutrition. BMI was slightly low at 17.8. She had typical thyrotoxic facies. The patient also looked restless. She had a decubitus of choice. No pallor, icterus, cyanosis, clubbing, or edema was present. There was a single neck swelling, which has been described later. No other neck swellings or engorged neck veins. No palpable lymph nodes, and no skin changes were seen. Regional examination. The patient was examined with proper exposure from head to mid-chest in different positions as and when required. On inspection, there was a bilobed swelling present in front of the neck on both sides, roughly measuring 5 by 4 centimeters each. The extent was between the medial borders of both sternocleidomastoids horizontally, uh, up to 1 centimeter, just above the sternal notch vertically. The margins were well defined on inspection with an apparently smooth surface. The overlying skin was normal. There were no sinuses, pulsations, or scar marks visible. The swelling moves upward with deglutition, and the lower border was clearly visible. On palpation, the inspectory findings, as mentioned above, were first confirmed. The temperature was normal. There was no tenderness. The swelling had a smooth surface with well-defined margins, firm consistency, not fixed to the skin or underlying surface. A thrill was palpable in the upper folds of both lobes. The lower border was distinctly palpable. No other palpable swellings were present in the neck. Trachea was centrally placed, and bilateral carotid pulsations were present. On auscultation, there was bruit present at upper poles of the swelling. Uh, in view of thyrotoxic facies, eye signs were elicited. Navziger sign bulging of both eyelids with a staring look was present. The Navziger sign was present for positive for exophthalmos. Lid lag was present. Dalrymple sign, Geoffroy sign, Mobius sign were present, but there was no evidence of keratitis, no evidence of loss of vision. Systemic examination, CVS cardiovascular system showed sinus tachycardia, but S1, S2 were normal and no murmurs were heard. The respiratory system, there was bilateral air entry was normal vesicular breath sounds, and no adventitious sounds were present. Per abdomen was soft, non-tender. The peristaltic sounds were present, and there was no organomegaly. CNS examination, the patient looked anxious. There were fine tremors present in the upper limb and the tongue. Deep tendon reflexes were exaggerated, and the power of bilateral lower limbs was 4/5. The upper limbs was 5/5. So my patient, a 54-year-old female, presented with complaints of swelling in front of the neck for 5 months, gradually increasing in size. Presently 4/5 centimeter on each side of midline. Painless, not associated with respiratory difficulty swallowing or voice changes. There was a history of weight loss despite increased appetite, limb tremors, heat intolerance, insomnia, easy irritability, diarrhea, muscle weakness, and palpitations. There was bulging of eyes for past 1 month, which all these symptoms were relieved on starting medication 1 week ago. No significant past history or family history. Married with 2 children and postmenopausal. On general examination, the patient is restless, shows fine tremors, sinus tachycardia, and has bulging eyes. The eye signs are suggestive of thyrotoxicosis are present. On local examination, there is a bilobe swelling in front of the neck in the midline, smooth surface, firm consistency, moving with deglutition, with palpable thrill and audible bruit. The provisional diagnosis is primary hyperthyroidism with thyrotoxicosis, probably a case of Graves' disease.
Yeah, come to the first slide.
Yes, sir.
Of examination. Yeah. You see, once you start the general survey, this patient is having a thyrotoxic look, so that should attract the attention first. So you can start with faces, a typical thyrotoxic faces. What is a typical thyrotoxic faces? What is a classic thyrotoxic faces?
So the patient has bulging eyes with a staring look.
Yes.
And yes, sir. And anxious look, sir.
Anxious look, and patient may have a swelling in the thyroid
Swelling
region.
in the neck, sir. Yes, sir.
Okay, fine. Next. Next slide. You see, when I always say that in the postgraduate level description, this patient is having a swelling in the thyroid region. Okay, great. And this swelling moves up and down deglutition. Once you confirm that the swelling in the thyroid region and moves up in deglutition, instead of, you see, till the end of your description, you have not mentioned that this is a thyroid swelling. You kept on describing this is a bilobe swelling in this region, dimension this, relation with the muscle is this. So
Yes.
I would prefer that you start the description of this particular scenario saying that thyroid gland is enlarged involving both the lobes and the isthmus region.
Okay, sir.
So you stop at this point. Let the examiner, why do you say it's a thyroid swelling? Why is a thyroid swelling? If you start the description like this, I come to the next part, how do you describe it? Why do you say it's a thyroid swelling?
Sir, present in the thyroid region and
Good.
moving upwards with deglutition.
Yes. What is thyroid region by anatomical description?
Sir, the thyroid gland is ideally located opposite the vertebra. Sir,
Don't by
see
vertebra, I can't from the front. Is in relation to the what?
the thyroid cartilage,
Isthmus,
sir.
yes. Isthmus in relation to the tracheal rings.
Yes, sir.
So the region of isthmus is in the
Second to fourth tracheal ring, sir.
yes. And how about the lobes? What is the lower limit of the lobe? If you
Sir,
go by just
sir,
above the sternoclavicular joint,
yes, sir.
just and above it extend up to the
Sir, the upper border, sir,
just
upward
below the upper border. There is
below
oblique
the
line, the
upper
thyroid
border of the
cartilage.
thyroid cartilage.
Okay, so if you have any swelling in this region, this should be assumed as thyroid swelling. And if the swelling moves and deglutition, you can straightaway start saying that here you said both areas involved, midline is involved. So you say diffuse enlargement of thyroid gland. And once you have this swelling being seen in thyroid region, and you start by saying the thyroid gland is enlarged, involving both the lobes and isthmus. Now you can describe the other dimension. In the midline, the isthmus region extends below this centimeter above the suprasternal notch. Each lobe extends below up to the sternoclavicular joint and above up to this region of the thyroid cartilage. Laterally, if you say is a 5 centimeter swelling, 5 is a big swelling, it may not be confined only to the anterior sternocleidomastoid.
Yes,
Got
sir.
my point?
Yes, sir.
If the thyroid lobe is 5 centimeter on each side, this has to go to the posterior sternocleidomastoid. So you have to describe the exact dimension. Most of the time, thyroid swelling bulges deep to the sternocleidomastoid, and you can appreciate the posterior border of the posterior border of sternocleidomastoid. So
Okay, sir.
you have to describe the dimension of each lobe, below,
Yes.
above, medially, and laterally. And then describe, on inspection, you have described as it's a smooth surface, margins are well defined, skin over the swelling is normal. Okay, palpation. You see, again in palpation, if you start describing the whole swelling, you need not write the term that inspected findings are confirmed, not necessary. In palpation, temperature over the swelling is normal, no tenderness, thyroid gland is enlarged, involving the isthmus and both the lobes. The isthmus region is this dimension. You see, you have not given the exact dimension again in palpation. So this dimension may vary to some extent.
Okay, sir.
And it's a smooth surface in both the lobes, no nodularity, lower border is palpable. Okay, so what I'm trying to say is you start the discussion saying that is the thyroid gland which is enlarged, and this is a palpatory finding.
Okay,
Okay,
sir. Yes,
and auscultation, you heard the bruit at the and in the same you say freely swelling the upper pores of both lobes. Okay, fine. Next. Now you say don't make a heading of eye signs only. What we're trying to say is you have to exclude some other findings. You make a heading of examination for toxic signs.
Okay, sir.
Where you mentioned pulse, you have already mentioned. Just again mention the pulse, patient goes tachycardia.
Okay, sir.
Number 2, you mentioned the patient has got these eye signs.
Yes, sir.
Next is tremor.
Yes,
Okay.
sir.
Presence of any pretibial myxedema.
Yes, sir.
Okay, so they are the eye signs. Examination for retrosternal prolongation. Lower border is seen on inspection, lower border is palpable, no evidence of retrosternal prolongation. You need not do the Pemberton side.
No, sir.
Because here you can see the whole gland and you can see the lower border also. Next. System examination is all right. Next. You use the term sinus tachycardia. Next. I think you have mentioned the term repeatedly, saying sinus tachycardia.
Yes, sir.
On examination, you cannot make out sinus tachycardia. Sinus tachycardia is a ECG finding. Okay.
Okay, sir.
You
Yes, sir.
say tachycardia. Sinus tachycardia, clinically, you cannot say. It can be
Okay, sir.
tachycardia due to other reasons. So, say ECG finding saying sinus tachycardia. Okay.
Yes,
So, your diagnosis is primary hyperthyroidism with thyrotoxicosis. I mean, the Graves' disease. Uh, Again, the term of primary hyperthyroidism, secondary hyperthyroidism now is varied. What do you mean by primary hyperthyroidism?
Sir, primary thyroid hyperthyroidism refers to a state where there is increased secretion of thyroid or hormones due to a pathology of the thyroid gland, sir.
Yes. And secondary hyperthyroidism?
Sir, it might be, sir, the anomaly is at the level of the pituitary or the hypothalamus, sir, leading to increased secretion of TRH or TSH, which in turn lead to increased T3 and
Or it
T4,
can be an ectopic.
or ectopic thyroid
Yeah.
secretion like stoma
So,
ovaries,
so
sir.
the previous description of swelling coming first and then the toxicity secondary is over. So, primary is when the thyroid gland is primarily hyperfunctioning. Okay.
Yes,
And
sir.
you said the patient has got Graves' disease. So, there
Yes,
are some criteria to define Graves' disease.
yes,
What are the criteria to say patient is having Graves' disease?
Sir, in Graves' disease, sir, there will be sir signs of hyperthyroidism
Yes.
with signs of um, sir thyroid ophthalmopathy will be present, sir.
Yes. What else? Thyroid ophthalmopathy present. Patient has features of thyrotoxicosis with primary hyperthyroidism, and another important finding is these usually occurs in females,
Female patients,
and
sir.
there is diffuse enlargement of the
Thyroid gland.
thyroid gland. And if you do investigation, what do you find typically?
Sir, TSH is very low with increased values of T3 and T4. Then we
And
can specific test for antibodies, sir, thyroid receptor stimulating antibodies and anti-TPO antibodies, thyroid
yes,
peroxidase,
so
which are
these are the
positive.
these are the two elevated classically in Graves' disease.
Yes, sir.
Okay, so
Yes, sir.
these are patient having these symptoms, and you suspect the patient has got Graves' disease.
Yes, sir.
What investigation you order for this patient?
Sir, in a case of Graves' disease, sir, we will do the usual quadruple assessment like we do for any thyroid case, sir.
Yeah.
Firstly, we have performed the clinical examination. Next, sir, we will do the biochemical examination, sir, TSH, T3, and T4. And in this case, we will also look for the specific antibodies. Then, sir, we will do the neck imaging in the form of USG of the neck. And, sir, we might take
Why,
USG
why,
value.
why is you have clinically assessed the patient has got a diffuse thyroid enlargement? Why is USG important in this patient? What do you like to see in USG?
Sir, whether it is whether there is any multinodularity
Yes. First thing
or
is
with the
the
sir.
character of the swelling.
Yes, sir.
If you say the classically Graves' disease, it will be uniform smooth enlargement,
Yes, sir.
or it can be a toxicity on the background of a multinuclear goiter,
Yes, sir.
or it can be that a one nodule is there in this enlargement, and that is hyperfunctioning. That means a autonomous nodule.
Thyroid nodule. Yes, sir.
And also you can assess the vascularity of the gland. You can assess the vascularity of the gland by doing a ultrasonography. Okay.
Yes, sir.
So that is the idea of doing ultrasonography in this patient.
Yes, sir.
Can there be a situation that patient has got features of hyperthyroidism in spite of having a normal hormone level? Can there be a situation that patient has got features of thyrotoxicosis on the background of patient having normal hormones?
Thyrotoxicosis.
Normal hormone means T3, T4 is normal. But
Yes,
what
sir.
is more important?
Sir, free T3 and free T4, sir,
Yes.
peripheral conversion
So,
might be
so,
increased.
so there is a situation where the free fraction of the hormone may be more, and that can cause thyrotoxicosis in spite of background of a hormone being normal on total value.
Yes,
Okay,
sir.
so that is important. Okay,
Yes,
so
sir.
you have to, in some situation, need to do even a free hormonal assay.
Yes, sir.
Okay, so now you have the situation that patient has got classic Graves' disease. You find that antibodies are positive. You have a diffuse thyroid enlargement and he has got this hormone being elevated. What is the management for this patient? How this patient has come to you in the surgical OPD, and you said she has started a drug on 7 days of last 7 days and she has some improvement. What should be your treatment strategy for this patient?
Sir, in a case of Graves' disease, sir, we will give antithyroid drugs and
Yeah.
adjunct in the form of beta blockers, sir, to control the symptoms, peripheral signs and symptoms, sir. And then to control.
This is the patient who will benefit from beta blocker. The history and the background you have given this patient.
Yes, sir.
Why?
So this patient has cardiovascular symptoms in the form of tachycardia
Yeah.
and
So
anxiety.
this
So
patient will be benefited by giving some beta blockers. Fine.
yes,
So
sir.
you have started the patient antithyroid drug and beta blocker.
Yes, sir.
How do you monitor this patient after you start the treatment?
Sir, firstly, with clinical evaluation, uh, we can look for resolution of any signs and symptoms, sir.
Yes.
And then secondly, sir, we can estimate the peripherally circulating thyroid hormone levels, sir.
So you start the therapy today.
Yes, sir.
At what interval? What is the recommendation to reassess the patient by investigation also? At what interval of therapy?
Sir, 6 weeks.
Yeah, usually 3 to 4 weeks. So at the end of 3 to 4 weeks, you review the patient and do the biochemical test because it takes time. Once you give the patient antithyroid drugs, it takes time for this to act.
Yes,
What are the drug you use in your practice?
Sir, antithyroid drugs, sir, neomercazole or carbimazole can be used, sir. Around 10 mg TDS can be given initially. Then, sir,
And, yeah.
sir, and then, sir, we
In
can
our practice, we mostly use this carbimazole or neomarcazole.
yes,
Okay.
sir.
And
Yes,
what are the other antithyroid drugs?
sir, propyl thiouracil or methimazole can be used, sir.
Yeah. Okay. So
Then,
how these drugs acts in patient having hyperthyroidism? What is the
sir,
mechanism action of these drugs?
propyl thiouracil acts by decreasing peripheral conversion from T4 to T3.
It's a added effect.
Yes, sir.
It has
And
got a primarily,
sir,
yeah,
organization of the thyroid and coupling of the
yeah. So it has got dual function. One is it blocks hormone synthesis in the gland itself, and also it prevents the peripheral conversion.
yes, sir.
Okay. Other antithyroid drugs are blocking the synthesis.
Yes, sir. Then, sir, in addition to antithyroid drugs, we can give propranolol, sir, 20 to 30 mg, sir, twice or thrice daily.
This can be increased. You see, 20 mg is a very low dose in patient having what thyrotoxicosis. You can increase this dose. Okay.
Okay,
So
sir.
what is the uh, strategy? Suppose you start this patient on antithyroid drug, and then what you think should be planned for this patient? You continue the antithyroid drugs, or there may be other options for treatment.
Sir, the definitive treatment can be given in the form of radioiodine ablation or in the form of surgical thyroidectomy, sir.
Okay.
So,
Tell
sir,
me, tell
after
me, tell me, tell me the advantage of radioiodine therapy over your antithyroid drugs and uh, the surgery. Why? Because you see, in the West, the more preferred treatment is radioiodine therapy.
yes, sir.
Why?
Sir, radioactive iodine can be given in patients who are not fit for surgery, like older patients, sir, or it can be given for small and moderate goiters. And sir, it can be given in cases where there is relapse after medical therapy, and in cases where there is intolerance to thyroid drugs, sir.
Yes. And and what is the age range where you can give this therapy?
Sir, earlier it was said that patients more than 40 years of age are to be given, but nowadays, sir, more than 25 years of age can
Hey,
be
much
given
less than that.
radioiodine.
Even after 5 years, you can give. The
Okay, sir.
contraindication is below 5 years.
Okay, sir.
And pregnant lady,
Yes, sir. Pregnant and
pregnant and lactating lady. Okay.
yes,
And
sir.
what is another advantage is if you give this radioiodine, you avoid the side effects of antithyroid drugs.
Yes, sir.
It is not a very invasive treatment.
Yes, sir.
So what are the drawback of this radioiodine therapy? You are giving the patient a mega dose of radioactive iodine.
Yes, sir.
So patient is exposed to some
Radiation exposure, sir.
yes, number one.
Then, sir, it cannot be given during pregnancy and breastfeeding.
And
sir, it can worsen the ophthalmopathy in Graves' disease, sir.
yes, and these are the patients who are likely to go into permanent
hypothyroidism, sir.
Yes. So how this radioiodine acts in the thyroid gland? What is the effect?
Sir, iodine 131 is used.
What happens to the thyroid follicular cells?
Sir, iodine 131 is used and it is preferentially taken up by the thyroid gland. It gets concentrated where it releases the ionizing radiation, sir, which destroys the.
So there is destruction of the follicular cells and fibrosis.
Yes, sir.
This radioactive iodine entering into the thyroid follicular cells destroys these follicular cells and this leads to fibrosis.
Yes, sir.
And this is the effect which keeps on going, and ultimately most of the patient go to phase of hypothyroidism.
Yes, sir.
So that is the disadvantage of radioiodine ablation. Oh, if the patient you don't have the facility for radioiodine ablation, you want to treat the patient on antithyroid drugs. So what is the optimal duration of this antithyroid drug treatment? What is the optimal duration of these antithyroid drugs treatment? How long you should continue this? Kamal, am I audible?
Yes, sir.
Yeah.
Sir, sir, I don't know the duration.
Yeah. So once you start the antithyroid drugs, the patient starts showing improvement in 4 weeks time. And by 6 months time, most of the patient respond well to this therapy.
Okay, sir.
And the optimal duration of treatment is 12 to 18 months. The idea of this treatment is, what is the natural history of Graves' disease? What is the natural history of Graves' disease?
Sir, it is followed by a period of hyperthyroidism,
Yes.
followed by a transient period of hypothyroidism, followed by euthyroid period, sir.
Yes, the natural history of Graves' disease is characterized by relapse and remission.
Yes, sir.
Okay, patient has got the phase of hyperthyroidism, and this patient can go to spontaneous remission. Yes. Even if you don't treat, the natural history means without intervention, what happens to this disease process? Even if you don't treat, this hyperthyroid state may go into euthyroid state. So the idea of giving antithyroid drugs are, you tide the patient over 12 to 18 months, and that is the time required for going to spontaneous remission. Okay, so you give the patient antithyroid drugs, follow this patient for about 12 to 18 months. Yes, and if the patient has come to euthyroid state, you can withdraw the antithyroid drugs. What is the problem? If you stop the antithyroid drugs at the end of 1.5 years, what might happen afterwards?
Sir, relapse might happen.
Relapse. So the problem is the relapse. Yes, so that the idea of the antithyroid drugs are to control the symptoms. Yes, sir. You block the synthesis and control the symptoms, and the idea of taking this drug to about these 12 to 18 months is to allow the patient to go into spontaneous remission. Once the patient go to spontaneous remission, you can take the drug off, and this patient should be followed up, because we are the patient who are likely to have a relapse of the disease. Okay, so that is a problem with antithyroid drug, that once you stop the drug, patient may have relapse, and you have to follow this patient up. Okay, so what are the patient come to you as surgical department? When do you take up? What are the indications for surgery for thyrotoxicosis? Indications of surgery.
Sir, either sir, if there is an increased predisposition towards carcinoma of thyroid, or if the patient
You see, if Graves' disease is per se is not a risk factor for high-risk carcinoma, okay, that is not the important factor for considering surgical in hyperthyroidism.
sir, if there's a large goiter with compressive symptoms, then
Yes,
sir, if the patient is patient has moderate to severe ophthalmopathy, sir,
yes.
and if the patient is willing to conceive within 6 months of therapy, and when we can't give radioiodine for that reason, then we can consider surgery, sir.
And you said you cannot give radioiodine in a particular
Intolerance,
patient.
yes, intolerance to antithyroid drugs or
Drug
other
intolerance and patient in pregnancy having severe symptoms.
Yes, sir.
What should be the ideal time during pregnancy you consider for doing a thyroidectomy?
Sir, third trimester, sir.
No, third trimester is a late. Final trimester. This is the second
Second
trimester. Mid trimester is ideal time for considering thyroidectomy in pregnant patient. And as you said, less than 5 years. Less than 5 years, you cannot give this patient radioiodine ablation.
Yes, sir.
Okay,
Yes.
patient developing side effects too. What are the important side effects of antithyroid drugs? What are the important side effects of antithyroid drugs?
Sir, bone marrow suppression, sir, leading to
Yes.
neutropenia.
Yeah. Neutropenia. It can be even a aplastic anemia.
Yes, sir.
There will be skin rash.
Yes, sir. Skin rash.
Okay, nausea, vomiting. These are the important side effects. Okay, so
Yes, sir.
if you are considering surgical treatment in this patient, what should be your plan for managing this pain by surgery?
Sir, if there is a very severe disease or a very large goiter, then or severe ophthalmopathy, we can consider total thyroidectomy. Otherwise, a subtotal thyroidectomy or Hartley-Dunhill procedure can be considered, sir.
No, you see, now the term subtotal is going off. Okay,
Yes, sir.
subtotal, the problem is it is difficult to assess how much to leave behind.
Okay, sir.
So it may be R on either side. So the ideal treatment for patient having Graves' disease should be a near total or total thyroidectomy.
Okay, sir.
What is the advantage? If you do this surgical treatment, what is the advantage of surgical treatment?
Sir, there's no recurrence, sir.
First is early control.
Yes, sir.
Once you do the surgery today, the thyroid hormone secretion is stopped.
Yes, sir.
So it provides quick control. Number one,
Yes, sir.
it provides long-lasting control.
Yes, sir.
What is the problem with surgical treatment? If you are doing a near total or total thyroidectomy,
Yes, sir, a patient will require lifelong supplementation of levothyroxine, and other
number
than
one,
that, sir, normal complications of thyroid surgery.
like
Sir, there might be local complications such as sir,
most the important complication which bothers the patient.
sir, recurrent laryngeal nerve
Yes,
palsy
and
due to hoarseness of
and
voice.
and recurrent palsy and if you're doing dual thyroidectomy, you're not very conversant with the parathyroids.
Sir, then hypoparathyroidism, sir.
Yes. So they're the two very important morbidity patient may have following surgical treatment. So they are the uh, problems of surgery. Patient will be rendered permanently hypothyroidism. Patient may have inadvertent recurrent nerve or parathyroid insufficiency.
Yes, sir.
Okay. So this patient you are decided to do surgical treatment. How will you prepare this patient for surgery? How we are going to prepare this patient for surgery?
Sir, we will control the hyperthyroid state of the patient first. Sir, we will give antithyroid drugs, carbimazole, 10 mg TDS for at least 6 weeks. We can give procanolol 30 to 40 mg TDS or BD for the same duration. Then, sir, before the surgery, we will have to give Lugol's iodine to the patient, 15 drops TDS for 10 days, sir.
Oh, I find Dr. Bhattacharya is there. Dr. Bhattacharya, oh, I did not notice you because it was not shown on my screen. Dr. Bhattacharya, Dr. Bhattacharya, Dr. Bhattacharya, you are connected. Dr. Bhattacharya, Okay, Komal, you said you will give the anti-thyroid drugs. You'll give the
Yes, sir.
patient beta blocker,
Yes, sir.
and you
And
said
lugol iodine, sir.
why? Why you want to give lugol iodine? How does the lugol iodine help? Nowadays, you are not giving.
Yes,
Yes,
sir.
that was also a description. How does the lugol iodine help in your surgery?
Sir, it reduces the vascularity of the thyroid gland by the Wolff-Chaikoff effect since it's supersaturated potassium iodide. So it decreases the chances of a thyroid storm during the surgery, sir.
Not thyroid storm exactly. The gland become more firm and rigid.
Yes,
It
sir.
become less vascular.
Yes,
So
sir.
surgery technically become easier.
Yes,
To
sir.
prevent thyroid storm, you have to give the patient what? Giving the patient
Sir,
antithyroid drugs.
yes, sir.
You see, if you give the antithyroid drug, there should be some improvement in biochemical parameters also.
Yes, sir.
Okay. Suppose this patient develops a reaction, some side effects of the antithyroid drugs, and you want to do the surgery. How do you prepare this patient for surgery if the patient has got some allergy to the antithyroid drugs? What
Sir,
should be the preparation?
beta blockers only, sir. Propranolol or nadolol can be used.
Yes. So in that case, you have to use very high dose of beta blockers.
Yes, sir.
Okay. How does this beta blocker helps in hyperthyroidism? Does it have
Sir,
any effect on the hormone
no, sir.
synthesis?
This is the
No.
sympathetic stimulation, sir.
So they are the patient where you should be very cautious. If you are not using antithyroid drugs and using beta blocker, these are the patient who can develop thyroid storm in the post-op period.
Yes,
And
sir.
how are you going to prevent that? You see, you have not given the antithyroid drugs. Patient has more thyroid hormone being secreted, being released in circulation.
Yes, sir.
How are you going to prevent development of thyroid storm during and after surgery?
Sir, by ensuring complete removal of the thyroid tissue, sir.
Yes. And
And
you
post-operative,
should,
you have to continue the beta blockers.
yes. So that is most important. You have good amount of thyroid hormone being in circulation. Idea of giving beta blocker is to prevent the peripheral effect of these thyroid hormones. So you have to continue this beta blocker, maybe in the parenteral mode, in the perioperative period.
Yes, sir.
Okay. How will you diagnose thyroid storm in the post-op period? What are the manifestations?
Sir, there will be a sudden rise, there will be onset of tachycardia, sudden
Yes.
rise in blood pressure, and sir, patient might complain of palpitations, excessive sweating.
You are not talking about the most important symptom. High fever.
Yes, sir. High fever will be
Patient
present.
has hyperpyrexia.
Yes, sir.
Increased sweating.
Yes, sir.
Hyperpyrexia, sweating. Patient may be in shock. Okay. So
Yes.
how do you manage? You suspect the patient is developing some features of thyroid storm. What should be the management? Where the patient should be treated? In the ward?
Sir, the patient should be shifted to a high dependency unit where the
Yes.
patient can be monitored, sir.
Yes.
And we have to immediately start antithyroid drugs and beta blockers to prevent.
Antithyroid drugs. How does antithyroid drugs helps? You see, thyroid is out. You have done the surgery. In the post-op period, patient developed the storm. Antithyroid drugs is not going to act.
Peripheral conversion of existing hormone can be.
No, in this case, it should be a purely a symptomatic supportive treatment. You give the
Okay.
patient cold sponging
Okay.
to reduce the hyperthermia, give the patient adequate beta blocker, do good hydration,
Yes, sir.
of the patient. You can give the patient steroid. Okay.
Okay, sir. Yes, sir.
So these are the measures. Because antithyroid drug isn't going to help. You see, once a patient has this hormone being in circulation and causing these features of storm, in that case, antithyroid drug has no role. Okay, you have to treat the patient symptomatically to tide over this crisis of this hyperfunction. Okay, said this patient has got ophthalmopathy. What are the different ophthalmopathy you may have in patient having hyperthyroidism? One is just a bulge,
Yes, sir.
exophthalmos.
Yes, sir.
What?
Sir, the
Yeah. What?
sir, exophthalmos is due to the forward bulging of the eyeball. There might be also palsy of the Muller's muscle, leading to lid retraction and lid lag, sir.
Yeah.
Then due to exposure, sir, there might be exposure keratitis.
When do you say patient has got malignant exophthalmos? Malignant exophthalmos is defined by what? There is a situation we call that patient is having malignant exophthalmos. This is a condition when the patient has got progressive exophthalmos, number one.
Okay, sir.
Patient has chemosis.
Okay, sir.
Patient has chemosis in the conjunctiva. Patient may have exposure keratitis or corneal ulceration.
Okay, sir.
Patient may have diplopia with paralysis of extraocular muscles.
Okay, sir.
And if not treated, patient may land up with blindness. So this is malignant exophthalmos. Okay. So this is a severe degree of exophthalmos. And this can happen following radioiodine therapy or sometimes with antithyroid drugs even.
Okay, sir.
How do you treat? How do you treat the patient who is going to phase of progressive exophthalmos? What is the treatment?
Sir, controlling the thyroid status, then sir, preventing exposure keratitis.
Yes.
By
What
using
are the measures? What drug you should give?
Sir,
Here the steroid acts very good.
Okay, sir.
You should give the patient glucocorticoid, number
Okay,
one. You can consider doing orbital decompression because these are all because of edema in the extraocular muscles and the retroorbital tissues. So in severe cases, you can consider doing orbital decompression. And now they are describing one drug, a monoclonal antibody, I forgot the name, some Darmotumab or some drug like that, which is a monoclonal antibody, which is having effect on this retroorbital tissues to reduce the edema.
Okay, sir.
Okay.
Yes, sir.
So what are the post-op complications following surgery? You have done a total thyroidectomy. What are the different post-op complications you expect in this patient?
Sir, there might be hemorrhage, there might be hematoma formation leading to respiratory
So
distress in the
some immediate complications. Immediate complications are post-op hematoma. What else?
Sir, post-op hematoma, then there might be sir, respiratory distress due to bilateral recurrent laryngeal nerve injury. So when the patient will need immediate intubation, sir, or a tracheostomy.
Yes.
Then, sir, there might be
Hemorrhage causing hematoma, bilateral recurrent nerve palsy. Next.
Sir, then there might be long-standing complications like unilateral.
Immediate complications. Patient with hyperthyroidism, you've operated, and some complication might come up within 24 or 48 hours. One, you say it is hematoma. Second is recurrent nerve palsy, which can be either temporary or permanent, which can be either a transient palsy or it can be unilateral, bilateral. Manifestations will vary.
Yes, sir.
And third is something can manifest within 24, 48 hours.
Sir, there might be hypothyroidism,
hypothyroidism will manifest later on. You see, patient is thyrotoxic. A thyroid may having so much of the thyroid hormone not manifest hypothyroid in the immediate post-op period. Hypoparathyroidism. How to diagnose? What are the earlier features? Because once you diagnose the patient in carpophoral spasm, you are too late.
So there will be periannular tingling and numbness. Will be the first complaint of the
patient can complain of periannular tingling and numbness. And if you stimulate some points.
Yes, sir. There will be jaw, sir, temporomandibular joint, sir.
Yes.
Sir, tapping on the temporomandibular joint region will lead to a spasming
twitching of muscle in the angle of mouth.
Angle of mouth, yes, sir.
Bostic sign.
Yes, sir.
You can press in the forehead. There will be twitching of the orbicularis oculi. Okay, so simple tapping can stimulate these muscles. Okay, so you find the patient is developing some features of tetany. How will you manage? Patient is developing some features of tetany. What is the management? What do you do?
Sir, IV calcium gluconate, sir.
Yes. And how much? How much? How much each ampoule of calcium gluconate contains?
No, sir.
It's a 10 ml.
Okay, sir.
10 ml, 10% calcium gluconate. So
Yes,
give the patient IV slowly. And now then you think that this patient has got a situation that all parathyroid might have been lost.
yes, sir.
A single shot of calcium gluconate will not be a remedy for this patient at this stage. What you need to give?
Sir, prolonged calcium supplementation will be
Yes.
required, sir.
Initially, in the immediate post-op period, you might need to give the patient calcium gluconate infusion
Yes, sir.
and start the patient on oral calcium supplement
Yes, sir.
along with vitamin D3,
Yes, sir.
125 dioxy calciferol. Okay, so that is how you should manage the patient hypoparathyroidism.
Yes, sir.
These are the patients who are hyperthyroid. When do you think the patient will go to the phase of U and hypothyroidism in the post-op period? What is the usual time interval?
Sir, the patient will go to a hypothyroid state, sir, 3 to 4 weeks after surgery, sir.
Yes, the half-life of thyroid hormone is about 2 weeks.
Yes,
So
sir.
beyond 2 weeks, these are patients who are likely to go to the phase of hypothyroidism, and these
Hypothyroid.
people will need lifelong replacement of thyroid hormones.
Yes, sir.
Any question in the chat box? I think. Yeah. Dr. Bhattacharya, can you hear me? Dr. Bhattacharya? I think he has some connectivity issue. Okay, Kamal, you have answered well. What I'm trying to emphasize to you is whenever you find a thyroid case, try to describe the swelling as thyroid.
Okay, sir.
Maybe a solitary thyroid nodule. In that case, you confirm that this nodule in the right lobe thyroid gland, and you find the right lobe is enlarged. You say the right lobe, you straightway say the right lobe of thyroid gland is enlarged. Let
Yes,
the
sir.
examiner ask the question, why do you say is the right lobe thyroid gland? Because it is in the region of thyroid, and this lobe is moving up and down in declination. And if it is a only solitary swelling, that is a situation you ask the patient to protrude the tongue. If it is a diffuse thyroid swelling, don't ask the patient to protrude the tongue, because you are not doing differential diagnosis with any of the thyroglossal cyst. If it is a diffuse swelling, only in solitary thyroid nodule, you may ask the patient to protrude the tongue. Okay.
Yes, sir.
Any other question from anyone? So you should keep in mind the options of treatment: antithyroid drugs, radioiodine, and surgery, and preparation for this patient for surgical treatment. Advantage of antithyroid drugs, disadvantage, advantage of radioiodine, disadvantage, surgery, advantage, disadvantage.
Yes, sir.
Okay.
Yes, sir.
If there is no other question, you can conclude. Okay, Milind? Milind, thank you.
Thank you, sir.
Okay.
Thank you, sir.
Thank you. Thank you. Come on.